GP Insights, a HealthCert podcast. Practical advice for busy GPs on how to treat with confidence and grow their practice.
So it's a pleasure today on the podcast to welcome Yevgeny Filanovsky, otherwise known as Gene. And it's a great pleasure to have Gene with us today, and not least because most of our podcast guests so far have been from Australia for very good reasons. But Gene is in Canada, and he's a very interesting beast because, like the rest of us, he's a GP, but he's in full-time skin cancer medicine. And I hazard to think that most of our Australian listeners would be surprised about that. So, Gene, maybe just before we jump directly into the therapies, just give us a short version of the practice that you're in and the colleagues that you have, because I think there's great interest in how your services. I've had a good look at your website, but our listeners won't have. They'll be interested to know what the clinic is like that you work in.
Yeah. So, David, I'm based in a community called Nanaimo, which is on Vancouver Island. Many of your listeners will be familiar with the city of Vancouver. Nanaimo is about 2 hours away by ferry. I arrived here 15 years ago to work at the regional hospital. I completed a residency in family medicine in 2001, but I never did any family practice. I went directly into further training in emergency medicine, spent my first career as an ER doc and a trauma team leader. And then in 2014, I started doing a day a month of skin biopsies and small excisions. My intent was just to cut back on shift work a bit, but the demand was huge. And over the course of the year, I kept getting asked to come in more often. I've always liked doing various procedures, so I enjoyed the work itself, but it's the patients who drew me in. As opposed to the high pressure, high anxiety environment of the ER, a skin cancer surgery is a fairly well-defined 15 or 20-minute interaction. There's time for a casual conversation. Yep. And I found I really enjoyed getting to know my patients and hearing their stories. So, so now I'm doing full-time skin cancer medicine. Our clinic is called Skin Care West on Vancouver Island here. And we're a team of 8 physicians, 3 dermatologists, 4 family physicians who do a mix of dermatology and other things. And then we have 1 proceduralist who comes in.
Yeah. It's very interesting. We'll move on to the specific clinical topics in a moment. But as our listeners would appreciate, here in Australia, this, well, I won't say this doesn't happen, because there are settings where dermatologists, a small number of settings where a dermatologist might have 1 or 2 GPs working in his or her clinic. And indeed, more and more dermatologists are using, let's call it physician assistants in the broad term, clinical assistants, alongside to do various things. But the sort of practice that you describe, where it is, as you say, collegial and collaborative and shared, if you will, it would be most unusual here. Let me be politically appropriate and just put it that way. So it's very, very interesting to see. And I would recommend that colleagues that are interested in looking at this to jump onto your website, which is very easy, skincarewest.com. So, Gene, let's talk a little bit about clinical. I know you wanted to share a couple of topics, and let's talk about these in turn. One is the use of the combination of 5-fluorouracil with calcipotriol. Many of us use that here. Some colleagues of mine have been using it for quite some time, but it's certainly very popular at the moment, and more people are starting to use it. What's your experience, and what's your perspective?
Well, a couple things, I guess. The first is to say is that when I went into training at UQ back in 2016, it really feels like AK went through a bit of a major paradigm shift. There's a lot of talk around melanoma and immunotherapies and things like that. We don't talk about AK as much, but a lot of the things that we thought about with AK in terms of looking for keratosis, treating keratotic lesions with cryo, those kinds of things were really challenged because AK has almost, two different entities, right? One that's hyperkeratotic and one that's actually proliferative and growing downwards. And so as we started to understand that process, it became more and more clear that field therapy, first of all, is absolutely essential. You can't just treat AK with cryo, you're not going to get anywhere. And so then the question became, well, which field therapy is the right one? And, because I went into skin cancer medicine with zero knowledge of skin cancer, really, I had been in acute care that whole time. I was very open to options, and I started, I was using all available options initially. So I was learning about imicomod, and I did daylight PDT, I still do, and 5FU predominantly, a little bit of Picado. And so initially it wasn't quite clear. And then I would say, 2018, 2019, there's a New England Journal of Medicine article that many of your listeners will be very familiar with, right? Comparing 5FU, imicomod, PDT, and inguinal mebutate. And 5FU was very clearly the dominant treatment. And then there's Martin Weinstock in JAMA Dermatology around the same time, looking at specifically at 5FU and the reduction in skin cancer, squamous cell cancer. You looked at basal cell cancer as well. And that was one of the first studies to really show that it worked on the endpoint that we really cared about. Later on, that became even more relevant when Picado got pulled off the market, right? So we were targeting keratosis, and we were grading the effectiveness of these treatments by how well they cleared keratotic AK. But what we really needed to care about, should be caring about, is does it reduce the incidence of squamous cell cancer? And so 5FU, I think, it really established itself as the foundation for treating actinic keratosis. 5FUC or FUCal, or there's different names used for it. The first paper that came out on this was in 2017, right? It was a Journal of Clinical Investigation, and it was a single center study, I think 130 patients or so, and it really looked amazing. You're achieving the same thing as multiple weeks of 5FU in 4 days. One of the things about those studies that established 5FU is that they all used it for about 4 weeks, I believe. That's a hard sell for patients. It's not many patients tolerate 4. Most of my patients tolerate 2, and they are not happy about it. So Agreed. To have a treatment that could achieve the same thing in 4 days looks so promising, but it was concerning. A single center, we didn't have any experience with it. There's this deep experience with 5FU. It's been around for decades. And so initially when it came out, what we would do is we would kind of select out patients we often labeled them as dabblers. So these are people, you'd put them on 5FU and they never, ever did a solid treatment. They wouldn't do 2 weeks or 3 weeks. They would do 2 or 3 days. And then they'd get a little bit of erythema and they'd say, oh, that's great. They come back in and say, look, doctor, I did my treatment and they're not any better. And you're saying, how long did you use it? Oh, 3 days, doctor, So those, I just started switching them over. I figured, listen, if you're going to do a short course anyway, let's try this combined therapy and see if it works. Right. And, it wasn't a large number of patients. But it looked promising at that point. And then what happened was in 2019, a second study came out as a follow-up study from the same group, where they showed that it actually reduced the risk of squamous cell cancer. And effectively was the same as the Weinstock paper a few years prior. So the numbers are smaller, but the reduction is about the same. So it's like a 75% reduction, I believe, at least in the first year or two. So that was very interesting to us. That came out in 2019, and then COVID hit in 2020. Yep. And that really changed everything because we went to video, and now everyone's wearing masks at home, and they are suddenly, they have time on their hands, and suddenly they are extremely motivated to do field therapy, basically. And it's it was fairly straightforward to talk to people about doing a 4-day treatment. When you're on video or on the phone with them and you're doing photo sharing and you're saying, listen, just pick a time. It's just 4 days. We'll see how you do. And then, and we would plan to see most of these people in the clinic afterwards. COVID hit, everybody thought, well, this is only going to last for, whatever length of time. Certainly the patients thought it was going to be like next month, I'll see you in the clinic, let's do this 4-day thing and I'll see you next month. You can check and see how it goes. So we really started using it a lot in, I would say, early 2020, and then built up experience with it. And now I would say the majority of the patients we put through field therapy are on 5-FUC. We still use 5-FU. It still has a role. We're still learning about 5-FUC. I would say there's a lot of information we don't have, especially in terms of how to titrate it on different body areas. We know with 5-FU, just because of historical use, we kind of know it's going to take longer on thicker areas of skin. It's going to take longer on the scalp and the face, or longer on the arms than the face. But we really don't have good data for that with 5-FUC. So we're kind of extrapolating from what we know with 5-FU.
I mean, it's very interesting, and this mirrors my experience. I've been using it a lot in the last 6 to 8 months, where I am on the Sunshine Coast in Queensland, and here there are very, very high levels of field cancerization. And just like you say, I mean, I actually do not have cryotherapy in my rooms anymore. It's just pointless, in my view. There's just no place for it now in the treatment of actinic keratosis. So I just don't have a flask of cryotherapy anymore. And I'm certainly using, I like you, do photodynamic therapy, conventional under the LED, and get very good results from that. But I'm very attracted to the combination cream. I call it rapid solar repair. Got to call it something. So that's what I call it. And I'm finding absolutely superb results on the face and the scalp and the décolletage. You don't get as big a reaction on the arms, I'm finding, even when you persist for, even 10 days. But like you, I agree with your evaluation there. I think the jury's out. I mean, are we seeing the reaction there? That is the arm's reaction, and we get a positive benefit. It certainly seems to treat the actinic keratosis. It just doesn't give you a florid response. I've tried it on a few patients on their legs, but to me, in my experience, the same as Epidix, it's pretty much a waste of time on the legs. So I'm a big fan of this combination cream, and I hope, and well, I'm sure there will be more and more studies coming out, observational studies that report, real world outcomes in practice. I mean, You've treated a lot of patients, I think over 1,000. Have you, or do you plan to audit those records at all and actually try and come up with some kind of sense of effectiveness in the real world, Gene?
Yeah, I don't have a specific plan to audit. I should also say, personally, I'm not sure I've treated thousands. As a group, I'm sure we've treated thousands.
Okay. Yep.
The only auditing I would say we do is that we still do a lot of photo follow-up. We have a clinic imaging app, so some of the pictures we're taking ourselves, some of the patients, but we really do follow these patients fairly closely. The vast majority, if I'm starting them on field therapy, I'm going to have a follow-up, probably 2 months later or something like that. And then we send them email-based reminder links about their appointment, and there's a little hyperlink on how to take photographs, a little presentation that they get linked to. So we actually get some very good photographs from the patients, and many of them take them during treatment, and they take them after. Some of them I also bring back into clinic after. We have in our practice, because we're the regional referral center, we actually have a lot of patients with very severe actinic damage as well. I think probably a very comparable population to what you would see in Australia.
Yeah.
And so some of these people are doing field therapy, twice a year, and we're excising multiple squamous cell cancers from them throughout the year.
Right.
So you get to kind of see them in the various stages of treatment. And to me, it looks very much like 5FU. It's a faster version, seems to achieve all of the same things. There's a few things I've learned over time with it. One of the things is I really emphasize with patients that it is an immunotherapy. It's not like 5FU plus. Even though I tell that to them, I say, listen, it's you combine these two medications, it's quicker, it speeds up the 5FU.
Yeah.
But I also try to emphasize that by combining the two, you're actually triggering your immune system off. It's quite a different mechanism than 5FU alone.
Right.
And that has some implications. Like I see more variability with 5FUC than I do with 5FU. It's very predictable. Put someone on 5FU and you say you're going to do so many weeks and this is what's going to happen. With the combination, there are some people who are exquisitely sensitive to it. We've had some patients who within 2 days they're red, they're crusty, they're done. And then there are patients at the other end too who are not at all sensitive, and so you start tuning it up. Do 4. Oh, 4 days wasn't enough. Let's do 6. Oh, 8. Let's do 8. And I've actually found that some patients essentially fail the treatment. They need to go back to 5FU because they end up doing half strength 5FU for a shorter period than they would with full strength, right? Because you're trying to get them to do, well, let's try 6 or let's try 8, when really what they need is 2 to 3 weeks of just good old 5FU. So there's also that end of the spectrum as well. But for the majority of patients, it's a much more tolerable option. They can find a 4-day window to do the treatment much easier than they can, to do 2 or 3 weeks. The recovery seems to be a little bit quicker too, a little bit less inflammatory response, and they like that. So, yeah.
Agreed. So one other question, and then we'll flip over to our other topic. But I agree with everything you said, and it resonates very much with my own practice, which is helpful. And I'm seeing exactly that spectrum of responses. A thought in my mind is for those that, if you will, fail the combination cream, I wonder whether the go-to treatment is PDT then for them, as opposed to Effudix. The only reason I say that, and very keen to get your view, is Effudix is so miserable. Mm-hmm. What do you think? Mm-hmm. What are your thoughts?
Great question. So going back to the New England Journal study that we talked about, where they looked at PDT, NGL mebutate, imiquimod, 5FU. It looked in that study like PDT was kind of a write-off, and I couldn't disagree more, to be honest with you. I believe it was a single cycle of treatment. There were some things in the PDT component of the protocol that could have been tuned. PDT has a benefit for specific types of patients, right? The patients who need the shortest possible treatment because they're working. They need that window of time. They need to be able to plan. I'm going to do my treatment on day X. The patients who prefer to have a clinic applied treatment, they're nervous to do it themselves. They would prefer to have a healthcare provider just, guide them through it, those kinds of things. And I also think PDT, there's a lot of potential with PDT to adjust the protocol and to get higher rates of cure, right? So I agree with you completely. I think imiquimod also has a role for some patients, and I still do use it sometimes. Early in my sort of skin cancer career, I was using the 3.75% Zyclera combination of imiquimod a fair bit, and I had great results with it, but stopped using it because the 5FU calcipotriol is cheaper and shorter. Yeah. But some patients fail 5FU. They do better on imiquimod, so it has a role there. With PDT, I'm a big fan of daylight PDT for AK.
Right.
And mostly because of the pain factor with field treatment with AK. It's hard to control the pain for some patients. A lot of patients who have had it in the past kind of don't want to do it again.
Sure.
We have nitrous oxide in our clinic. I don't know. Have you used nitrous oxide for pain control for these patients at all, David?
No.
Yeah. So the pain of PDT, as I'm sure you're well aware, can be hard to control sometimes when you're doing a field, right? You're trying to cool them down. You're trying to reassure them. You're just trying to get them through the treatment. And topical treatments don't do much for you there. It's hard to control with the topical. But nitrous oxide actually works pretty well. And there's a couple of studies that have looked at it and confirmed that. And that's something when I was in acute care and emergency medicine, I got very used to using nitrous oxide. I use it as an ER doc. I use it as a ski hill doc. And so we brought in, we have a tank at the clinic, and if we can't get you through PDT just through reassurance and cool air and all those things, then we give you some nitrous oxide to breathe, and that usually gets people through.
That's really interesting. That's really, really good, interesting to hear. Thank you for sharing that.
But yeah, I do believe, like PD.
Yeah.
Oh, go ahead. Sorry.
I was just going to say. Yeah. Go ahead.
I do like daylight PDT a lot as an alternative to 5-FUC, as a single day treatment, still applied in the clinic, but not painful. Very few patients complain of any discomfort with it. I mean, mild tingling. And they seem to really like the idea of, I can come to the clinic, I have this stuff applied, and then I can go sit in my backyard or local park. We have some benches outside the clinic. And when we were designing the facility, we actually did some modeling of the sun and where it would hit the facility, and kind of made sure we had benches in the right places so people could sit just outside the clinic if they wanted to.
That I like that as well. What do you particularly tell them to do in terms of daylight exposure? What's your protocol?
Great question. Yeah. So I've become increasingly comfortable with it over time in terms of extending some of the lengths of time that the approved lengths of time. So initially I was very much, 30 minutes and then 2 hours, and that's that. But I found that a lot of patients don't live close enough to the clinic to get outdoors within 30 minutes. And so I just warn them, if you go too long, you go outside, it might hurt a little bit more. You're going to have more protoporphyrin in your skin, but nothing terrible is going to happen. So it's 40 minutes or whatever it takes to get to wherever you're going to do your treatment. That's fine. And then the other thing I've learned is that with our climate here, because of the temperature issues, going a little bit longer is not a bad idea, especially on days that are a little bit overcast. So I'll push people to, 2.5 hours or somewhere in there to make sure that they really do activate the protoporphyrin completely. And then the other thing I do, which is off label, is some patients, I'll tell them, listen, why don't you come back and I'll put you under the red light. So if it's a day where the weather is, I'm not sure the weather is going to cooperate and they're a little bit nervous, that allows us not to have to cancel the clinic, the PDT clinic. They can still come in, they can do the daylight treatment, come back afterwards. And then we have a special instrument with a blue light. It's called the Lumio 2, and it's a 405 nanometer blue light with a filter, which we can use to take a look and see how much protoporphyrin 9 there is, whether it's photobleached or not, and then we can put them under the light if there are signs that it's worth it.
Okay. Yeah, no, well, that's very, very interesting. There are certainly doctors here in Australia who are very keen on PDT and use it a lot successfully. I don't, but only because I'm nervous. And here where we are, again, in sunny Queensland, the sun is just brutal. And I just get nervous about that. And, the dermal clinician that I work with, she and I have tweaked our protocol in such a way that we seem to be getting a very good reaction to PDT under the LED. And it certainly is uncomfortable for patients. But with her careful administration, it doesn't seem to be, well, we've certainly never had to stop treatment. And, a little bit of a cool mist and fan seems to get most people through, even if a number of patients do note that, well, that was pretty stingy, which in Australian means that was pretty awful. But they grin and bear it and get through it. So that's very, very interesting. Jean, this has been really helpful.
It was a pleasure. It was a pleasure to speak to you today.
Pleasure's all mine. I look forward to the next one. All the best.
Take care.
Bye.
Thanks for listening. If you like the podcast, please subscribe so you can get updates whenever we post more. And please share it with others. And for more info, please go to HealthCert.com.